Hello, everyone. Welcome, and thanks for joining us today for this webinar on the new guidelines for management of aortic disease that was issued by the American College of Cardiology and the American Heart Association. I am Chrisanne Campos, the Executive Director for GADA Canada, and with me co-hosting is Lindsay Rouge, the Vice President of the Board of Directors, GADA Canada. Before we get into this session, I just want to quickly point out the disclaimer for this session. Please be aware that the information in this session is for educational and informational purposes. If you are a patient or attending on behalf of a patient, please do not undertake any of the treatment, medication, or lifestyle recommendations without consulting your own doctor. A little bit about us before we get into the talks. GADA Canada is a registered patient advocacy organization in Canada. We've been in service for 36 years now, and with our expanded mission, we serve those individuals with genetic aortic disorders through our programs of education, awareness, research, and support. And one of the big research programs that we do support is the Montalcino Aortic Consortium, which is an international collaboration of clinicians driving precision medicine for genetic aortic disease. Today, we are really proud and honored to have with us the executive chair of the Montalcino Aortic Consortium, Dr. Dianna Milewicz. Dr. Milewicz is the President George H.W. Bush Chair of the Cardiovascular Medicine and the Director of the Division of Medical Genetics at the University of Texas in Houston. Dr. Milewicz is the past chair of GADA's Professional Advisory Board. And as I said, she is the executive chair of the Montalcino Aortic Consortium, managing and leading the largest aortopathy registry for research of genetic aortic disease. Thank you, Dianna, for being with us today and giving us your time just a day before Thanksgiving. Also with us is Dr. Jennifer Chung, Cardiovascular Surgeon from the Peter Monk Cardiac Center. Dr. Chung is the director of the Thoracic Aortic Surgery Clinic at the Peter Monk Cardiac Center, and she's the co-program director of the Advanced Aortic Surgery Fellowship. She focuses on both open and endovascular aortic repair. And so, without further ado, I will hand over this talk to Dr. Milewicz. Just make sure as the talks are going on, please feel free to send in your questions through the Q&A or the chat box. This webinar is being recorded and will be available on GADA's YouTube channel after the event. So without further ado, Dr. Milewicz, I hand over this talk to you to educate us on the guidelines for genetic aortic disease.
Great, thank you. Just pulling up my slides.
Yeah.
Can everybody see the slides okay? Well, thank you for the invitation to talk to you about the 2022 ACC American AHA guidelines. The guidelines are pretty extensive and involved all aortic disease, both thoracic and abdominal aortic aneurysms. What I'm going to emphasize today, and I think Dr. Chung is also emphasizing during her talk, is specifically the importance of genetics in not only identifying individuals at risk, but also defining how to manage people that have genetically triggered aortic disease. This is the mission of GADA, to really provide the best care and outcomes for patients with genetically triggered aortic disease. So I'll be emphasizing what's been updated from the 2010 guidelines. I sat on the 2010 Guidelines Committee, and I was also on the 2022 Guidelines Committee. So, and made certain that the genetic basis of this disease was addressed, and also that the patients were managed correctly based on the genetic information. I'm going to talk just at the beginning about some of the general things that are new to these guidelines that should affect the care and management of patients with aortic disease in the US. And I hope these guidelines are extended into Canada, also these first principles. The first thing was it was recognized that if you have a multidisciplinary aortic team, that patients have better outcomes. When they have either urgent repair from a dissection or repair for complex disease, and that includes genetically triggered vascular disease, aortic and other vascular disease. So this was right at the beginning of the treatment guidelines that if you have these teams that involve a cardiovascular surgeon, a vascular surgeon, anesthesiology, imaging, genetics, pathology, and cardiology, that the patients actually do better with that kind of team working together for the care. And this is something where it's being formed sort of both in Canada and the US, that there are major referral centers for very complex aortic disease. So these are the recommendations related to that. For patients with acute aortic disease that requires urgent repair, and this is really referring primarily to acute aortic dissections and aortic rupture, that a multidisciplinary team should determine the most suitable intervention. And for patients that don't have that acute disease, but have extensive disease and may be benefit from open or endovascular repairs, that they go to a center that has a high volume and has a multidisciplinary aortic team to optimize the treatment guidelines. So I think this, and the idea for this really comes from this data here, that this is the mortality of aortic cases based on the number of cases a center does. So here's, if you'll just focus on the red lines, this shows you when the centers do less than 5 aortic cases a year, that the mortality is pretty high, but it goes down as they go up to 10 cases, to 20, to 50, and greater than 50. There's this progressive drop in mortality. So this really argues that there should be tertiary referral centers for complex aortic care, both in the US, and I hope this extends into Canada. And this might be a good initiative for GATA to really push with the individual provinces in Canada. Next is the idea behind shared decision-making, that in patients with aortic disease, shared decision-making is recommended when determining at what size the aortic aneurysm should be when you go to surgery, deciding what type of surgical repair, and for disease that involves the descending thoracic aorta, what kind of, whether it should be an open surgical repair or endovascular, and also shared decision-making in terms of medical management and surveillance. And this is because of the fact that, first of all, for many of these conditions, we don't have a huge amount of data to really dictate, and don't have good evidence in terms of when to do the repair, what kind of repair to do. So to sit down with the patients and say, here's the data we have, this is what is your options are. And even the doctors can take it. I typically take it one step further and say, if it was me or my family member, I would choose this option, but these other options are open. And So that idea that aortic disease needs to often be managed with a discussion with the patients, presenting the data and discussing with the patient what decision is made in the care of that patient. And this is really true for patients with aortic disease who are considering getting pregnant or who are already pregnant, that we don't have the data we need really to define what the risk is during pregnancy, whether it's a patient with genetically triggered disease or a bicuspid aortic valve and so on. So everything needs to be like talked with the patient and the family, and the physician provide the data and have a shared decision making in terms of what to do. So those two things are really emphasized throughout the treatment guidelines. And when we talk later about the threshold for surgery for different genetically triggered conditions, the recommendations are based on really sending somebody to centers that does more than 20 cases a year. Because when you're making that decision in terms of referring somebody for surgical repair, it's a balance between will that aneurysm dissect versus the risk for surgery. So if we get that risk for surgery down to a manageable level, we can bring down the size of the aorta that we recommend be repaired. And so keep that in mind when you listen to the recommendations for anything surgical. It's based on going to a center that does a lot of cases, and that it's not really based on the numbers, at least greater than 20 cases a year. And I just want to mention that in the guidelines, this is the list of a partial list of the causes of aortic disease. So right up front on this list are all of the syndromic causes like Marfan's, Lois, Dietz, vascular EDS, smooth muscle dysfunction syndrome, and then all the genes that trigger familial disease, including ACTA2, MYH11, PRKG1, myosin like Chung, MYLK, and others. And they are up from and mentioned first in the causes. And then we come down to further down the table is the congenital causes like bicuspid aortic valve, Turner syndrome, and so on. And then hypertension is listed after that. And the list goes on, then I don't show you everything here. That I really wanted to illustrate that the genetic triggers for this disease is really recognized in the treatment guidelines, these updated treatment guidelines. So why is that the case? And we know from work for my research program and others around the world that 1 in 5 patients, up to 1 in 5 patients with thoracic aortic disease will have an underlying change in their DNA. It is typically just one base pair change out of the 3 billion base pairs we have in our DNA. And that occurs in a gene that causes a high risk. And that genetic change causes a high risk for thoracic aortic disease and can be passed in families from one generation to the next. So we're talking about Marfan syndrome and Lois Dietz syndrome, but we're also talking about families like John Ritter's family. He had a dissection in his mid-50s. His father died suddenly with chest pain and most likely died of a dissection. And after John's death, we imaged everybody in the family, and it turned out his brother had an aneurysm. His brother had his aneurysm surgically repaired and is alive 20 years later. So John's death really, due to dissection, was like a red flag that there might be other people in the family at risk. And we can pick those up whether we know that what that change in the DNA is or not. We can pick up the other family members by imaging them for asymptomatic aneurysms. And once we know they have an aneurysm, whether we know the gene or not, that we can put them on protocols to prevent the dissection. And that by and large is just giving them drugs to slow the rate of growth. And that's mostly beta blockers and angiotensin receptor blockers like losartan, and then image them routinely. And once they reach a certain size, send the individual to have the aneurysm repaired to prevent the dissection. So once we have the underlying gene, we can be much more precise in the management, and I'll be talking more about that in just a minute. The other 80% of the people that don't have a single gene alteration, and remember that is still the majority of people, we still think they have an underlying genetic variant, but it's not as highly penetrant. So we really have to know these variants going forward to be able to identify everybody in the population that is at risk for a dissection. But right now we can prevent 1/5 of the dissections that occur just by recognizing that they're familial, whether we know the mutant gene or not. And so that's really what's been emphasized in this. And the second part, I'll just talk briefly about the changes for syndromic and recommendations. So one thing that we emphasized in the treatment guideline is what are those clinical features that really tell you somebody has a genetically triggered thoracic aortic disease or a heritable thoracic aortic disease. And here's a list of those clinical factors that really identify patients. The patients with thoracic aortic disease that have syndromic features of Marfan's, Lois, Dietz, or EDS, we can pull them out of the general population for vascular EDS in particular, pull them out of the general population as being at risk for aortic, having an underlying genetic cause. Another clinical risk factor is having that family history of either thoracic aortic disease or aneurysms in the peripheral arteries or in the brain in first or second degree relative. So we use this family history a lot to figure out who might have familial disease and go after imaging everybody to find other family members that have those asymptomatic aneurysms, so we can prevent dissections in them. Also, if there's a history of unexplained sudden death at a relatively young age or in a first or second degree relative, we consider that as a possible dissection. And the John Ritter story was an example of that. His father died in his early 60s without having any significant medical history, and dropped dead suddenly after grabbing his chest. And that, given John Ritter had a dissection, most likely his father died of a dissection. So even those unexplained sudden deaths can be a hint that there's a heritable thoracic aortic disease. And then finally, we consider thoracic disease presenting under the age of 60, that it most likely has a very strong genetic trigger that's driving that early onset disease. Because that's what we see in Lois, Dietz, in Marfan's, and a lot of the familial disease, that they tend to present at a much younger age. So the treatment guidelines. So this is the recommendations for genetic testing and screening family members. And the first thing is a very simple recommendation. Anybody who comes in with aneurysms or dissections, we have to get a family history. It has to ask about unexplained, thoracic aortic disease, but also unexplained sudden death and other aneurysms outside of the aorta. Next, in anybody with aortic aneurysm or dissection and those clinical risk factors for nsHTAD, genetic testing is recommended to identify those pathogenic or likely pathogenic variants, or what we used to call mutations, that is causing the disease. So if we take somebody with a family history with syndromic features, we can find the gene maybe in about 80% or 90% of the cases. But if we take somebody just with the family history, that finding the gene suddenly drops down to about 30%. And that's because we just don't know all the genes yet. And my group and other groups are working very hard to identify all the genes, but we're up to over 20 genes now. And that the fact that as you go from family to family, it can be a different gene, makes it very hard to find all the genes. And so we're trying to, with machine learning and other techniques, to move from just standard genetic statistics to much better research to be able to find all the genes. But right now, anybody with any of these features here, those clinical risk factors that has thoracic aortic disease, we recommend genetic testing for those individuals, even though the yield is on the low side for if you don't have those syndromic features. And that's because once we find the gene, we can be very precise about how to manage the patient to prevent those aortic dissections in any of the family members. And then if you have one of these mutations or pathogenic variants in a gene known to cause heritable or genetically triggered aortic disease, it's recommended that genetic counseling be provided so that everybody understands in the family how it's inherited. And it tends, almost all these genes tend to be inherited in an autosomal dominant manner. That means that it can be passed from one generation to the next, and somebody with the disease has a 50-50 chance to pass it on to each individual child. And after, if the gene's identified and at that point, the patient's clinical management should be based on the gene, and in some cases, even the specific variant in the gene. And this is data mostly coming out of the Multidisciplinary Aortic Consortium that GATA funds. And I'll talk more in just a minute about some of that data and why this clinical management be gene-based, why our data is saying that is the case for all genes. And then finally, everybody with one of those changes, mutations, or pathogenic variants in the gene, you have to test all the at-risk family members, and that's called cascade testing. So let's say you test your parents and dad has the mutation, you find out he has an aneurysm, then you've got to move to his siblings. And let's say his brother tests positive, then you've got to move from your uncle and test all of his children, which would be your cousins. But once somebody has it, let's say your father's sister doesn't have it, then you can stop there. You don't have to worry about your aunt's children having disease. So that's what we call cascade testing. And if we don't know the mutation, we do cascade imaging. So if let's say we test you, you've had aortic disease and your grandfather died of a dissection, we would know the connection between the grandfather and you would be at risk. So let's say that's your father, we would image him. Whether he had an aneurysm or not, we would go ahead and start imaging his siblings. And if anybody is found with an aneurysm, we would image their children. So we can use testing, genetic testing, and if we don't know the mutation, we can do imaging of at-risk members. And I just want to mention why we want to move to precision medical care. And the Multidisciplinary Aortic Consortium, once again, that is completely funded by GATA and the Timothy Family Foundation, that its clinicians and scientists around the world are putting their patient's data into the database after the patient's consent. And then we analyze the data and we can come back with management guidelines for precision medicine based on the gene and the variant, and take that back to patients and their family members, that gene-based management. And just to show you here what a big difference it can make, this is the age of onset of disease of all those Lois-Dietz syndrome genes that are all grouped together. And this is the age that an individual with a mutation in either any of these different Lois-Dietz syndrome genes, what age they had their first aortic event. And we define that as going in for aneurysm repair or having a dissection. And so you can see right away that TGFBR2, the red line, has the earliest age of onset, and that's shown here with these two lines, that 50% of the people have their first aortic event by the age of 40. But if you look at SMAD3, it's much later onset, and 50% of the people don't have their first aortic event to 15 years later. So we need to be more aggressive about TGFBR2 than we do SMAD3. And then if you look in childhood, this is TGFB2 and SMAD3. Once again, all this is grouped under Lois-Dietz, and we should be managed this based on the individual gene that's not altered, not based on a diagnosis of Lois-Dietz. And it's shown here that if you look under the age of 20, just TGFBR1 and 2, the red and blue lines, the red and the blue shown here, those are the only genes that have aortic events associated in childhood. So we know that some of the children with mutations in these genes need to be even aggressively managed in childhood, but that's not the case for SMAD3 and TGFB2. All the aortic events are occurring after the age of 20. So we don't need to be as aggressive with SMAD3 in childhood as we do TGFBR1 and 2. And these changes are even more dramatic when we go to the other genes that cause people to have nsHTAD, but without those syndromic features. And here you consider this is PRKG1, and the age of onset is actually the earliest of any gene. It's in its late 30s. Here's ACT2, and you're talking about around the late 40s. But here's myosin late chain kinase. This is picked up the 50% of the people do not have an event until they're over the age of 70. So this is very late onset disease. So we want to be able to translate these findings into very precise management that's both prevents the dissection, but also limits the healthcare costs and the amount of imaging that somebody has to come in and do, and the amount of radiation they're exposed to through that imaging. And this just shows that you, even with a particular gene, we can make a decision about the management. Here's TGFBR2, and this is that arginine 528. And you can see everybody with that variant has onset, almost everybody has onset of disease in childhood. So if you have a child with this variant, you have to be aggressive in the management of the aortic disease. And over here is ACT2, and this is the smooth muscle dysfunction syndrome mutation, arginine 179, that all the children have aortic events under the age of 20. So that we, like I said, it's not just the gene. In some cases, it's a specific variant where we know we need to aggressively manage children with this variant in ACT2 and this variant in TGFBR2. So what about families? So next, I'm just going to talk about what about families where you don't know the gene. And this is the recommendations here in a family with aneurysms or dissections. If the disease-causing variant is not identified, you have to do that cascade aortic imaging of at-risk relatives. And we once again are calling that cascade testing or imaging based on the family members and who has disease and who doesn't have those asymptomatic aneurysms when we go to image them. In patients with aortic root aneurysms or dissections, in the absence of either a known family history of aortic disease or an identified variant, screening of first-degree relatives is recommended. So anybody who has an aortic aneurysm or a dissection, we need to image the parents if they're still alive, the siblings, and the children. And that is once again, because 1 out of 5 of those patients, we will find a family member affected, and finding that family member will potentially, will hopefully prevent any further aortic dissection deaths in that family. And then finally, patients with acute aortic dissection, we want the diameter of the root and an ascending aorta to be recorded in the operative note and in the medical record. Because when we go to manage families where we don't know the gene, we recommend surgical repair based on the size of the aorta when other family members have dissected. So we as physicians, and even you as family members, need to know how to go into the medical records and find that information rapidly. And even the surgeons like putting it into the operative note, because if the patient comes back after the dissection and they haven't repaired a portion of the aorta, like commonly they will not repair the aortic root, even if it's slightly enlarged, because they're just trying to get in there and save the life of the patient. They can look back at the op note and know the size of the aortic root at the time of dissection, then look at their patient later and see if it's actually increased in size. So the surgeons even like putting it in the op note. So finally, this is just briefly the surgical, how we decide on surgery if we have somebody where we don't know the genetic cause. So if we don't know that genetic cause, we can't go to precision medicine. We have to rely on what's happened to other family members. So if you have a patient with an aneurysm and a family history and no gene, determining the timing of surgical repair requires that shared decision making because our information is limited, and it's informed by the aortic diameters at the time of dissection or aneurysm repair in or both in affected family members. So if we know that somebody had aneurysm repair when their aneurysm was 5 centimeters in a family where we don't know the gene, and somebody else has an aneurysm that's 4.5, we're not really pushed to repair at 4.5 if we know somebody else in the family, the aneurysm could grow to 5 and they did not dissect. So in asymptomatic patients with aneurysms and no identifying cause, but there's no information of the diameters or at the time of dissection or at aneurysm repair, the recommendation is 5 centimeters. So we just go back to the standard of care. But in patients where they have, in the case where they have no genetic cause and the aorta is greater than 4.5, if they have any of the high risk features for adverse aortic outcomes, or who are going to surgery anyway for other reasons like repair of a bicuspid aortic valve, it's reasonable to go ahead and repair the aorta at that time. So these are the recommendations. Just briefly, I want to say that we did address the medical treatment for Marfan syndrome with the recommendation that either a beta blocker or an angiotensin receptor blocker in the maximally tolerated dose is recommended to reduce the rate of aortic repair. And actually using both is reasonable. And there's some new data that's been out since the treatment guidelines were written and finalized that show that possibly treatment with both are the best. And I will go ahead and defer to Jennifer now for the replacement of the aortic roots and the size of repair for people with Lois-Dietz syndrome and further data. So I'm going to stop there. I don't know if we want to take any questions now at this point, or wait until after Jennifer's.
Yes, so thank you, Dr. Milewicz, but I think we'll do the questions after Dr. Chung has finished her talk.
Okay.
Hello. Okay. All right. So I'm Dr. Chung. Thanks for inviting me to give this talk and to join you. So today I will be focusing on the surgical timing and treatment approaches for genetic aortic disorders. And no disclosures. So this document that we're speaking about today, the 2002 ACC AHA guidelines for the diagnosis and management of aortic disease, is a major update from the previous documents that we've had before to guide us, and it's a great document worth reading for sure. It codifies a lot of what a lot of us are already doing in aortic clinic, and one very excellent feature is the specificity with which it goes through the genetic disorders that we didn't see in previous guidelines, and that's for sure thanks to Dr. Milewicz's work. So before we get into the specifics of size thresholds for particular genetic disorders, I wanted to go over the major themes that have popped up in the guidelines, just as Dianna already went through. So the first theme is the idea of size threshold. So this is long established that there is this size association, that the larger the aneurysm is, the higher the risk of aortic events, specifically dissection, rupture, and death. And so I just have here the original seminal work from Eleftheriades group that showed this hinge point rise in complication rates at 6 centimeters for thoracic aortic aneurysms. And this is the reason why we have this 5.5 centimeter a number that we sort of started off at. And so working from here, though, we then move the needle depending on a number of risk modifiers. And so this includes the actual genetic diagnosis. So you've heard Dr. Milewicz talk about precision medicine and the idea of personalizing these size thresholds based on the actual diagnosis, even down to the base pairs. So we talked about family history, how rapid the aneurysm is growing for sure influences how we move that needle, and whether concomitant surgery needs to be done also influences our size threshold. So these will be recurring themes that come up during this talk. And another theme that is prominent in the new guidelines is this idea of shared decision making. So there isn't going to be a magic number size threshold to cling on to for any given scenario. This is always a complex issue. When we talk about risk management and determining risk profiles, it's all about preventing an event that hasn't yet occurred. So we have to factor in the patient's values in terms of their comfort level with the risk of surgery, as well as the risk of aortic complications happening without surgery. So this is always an ongoing conversation, and it's never just a single number to hang your hat on. Finally, this was already touched on by Dr. Milewicz, but I wanted to bring it up again. This is because it is a very prominent theme that occurs throughout the guidelines, this idea of the multidisciplinary aortic teams. And just as a preview, I do think it is going to come in Canada. These multidisciplinary aortic teams already exist, of course, including at Peter Mount Cardiac Center, but I am on the panel for the CCS panel on complex aortic diseases, and we are actively working on a document that also speaks to the need for these multidisciplinary teams. The idea is that surgery for the aorta in 2022 is quite complex and very different from what it was maybe decades ago. And so surgery for this population requires expertise from cardiac surgery, vascular surgery, and the guidelines also comment on endovascular specialists. So this could be interventional radiology or from the cardiac and vascular teams themselves. It doesn't mean that all of these specialties necessarily will be involved in the surgery, but conversations should be had when it comes to between the teams, whether in the form of a multidisciplinary clinic or in the form of rounds. But the days of working in silos will hopefully be behind us. And the guidelines also talk about the idea of centers with high volumes of aortic intervention. So this highlights the importance of the overall infrastructure of the whole aortic team beyond just the surgeons. It's really not just about the surgeons. Even outside the clinic with the geneticists and cardiologists and imaging specialists, and focusing on the surgery itself, we have the ICU infrastructure, the intensivists, the anesthesiologists, and all of the team players that are involved. And this is especially important for patients with distal aortic disease with that have a risk of spinal cord ischemia, for example. So Dr. Milewicz already very nicely illustrated the volume outcome relationship between for aortic surgery, and this is this particular diagram is pulled from the guidelines, but it's actually just one of many studies that show this recurring theme that the more aortic surgery you do, the lower your complication risks, such as mortality and major morbidity. And this is in both the acute setting in terms of aortic dissection, as well as in the elective setting. And so I just have this figure here on the right, and this was a case, a recent case of mine where it was referred from another cardiac surgery center when that team recognized that the aortic dissection was very complex. There was a lot of malperfusion happening, and was transferred down to Toronto. And I planned for this patient actually a 3-stage, and as you can see, quite a complex reconstruction of this patient's aorta. So now let's get into the specifics. So starting with non-syndromic heritable thoracic aortic disease, so with no identified genetic cause. So these are the patients. This is the 1 in 5 patients with aortic disease who do not have a multi-system involvement, but do have a family history of thoracic aortic disease. So what do we do for these patients? So the starting threshold, if you will, again, these aren't hard and fast numbers to hang your hat on, is 5 centimeters. But the risk modifiers to drop it down to 4.5 are family history of dissection below 5 centimeters, a family history of sudden death under the age of 50, and I would include also family history of aortic dissection under the age of 50, rapid growth, which they define as greater than 0.5 centimeter a year or greater than 3 millimeters per year in 2 consecutive years, or if the patient is undergoing other cardiac surgery. So if you're coming in to get your valve fixed at the same time, surely we will not leave the 45 millimeter aneurysm behind. So the next section is patients who have non-syndromic nsHTAD, but yes, they do have a genetic cause that was identified. So this again is all Dr. Milewicz's work. acted to a gene variant, if you don't have any risk factors, it's no longer 5 centimeters as your baseline threshold, it's 4.5 centimeters. And in fact, if you do have risk factors, that's lowered even further to 4.2 centimeters. And then you can see the numbers there for PRKG1. Okay. So then moving on to Marfan syndrome, the baseline threshold, surgical threshold there remains 5 centimeters, which is the same as it was previously. I put a little figure of the entire aorta there because it is very interesting that the guidelines suggest 5 centimeters, not just for the proximal aorta, but also for the distal aorta, for the descending thoracic and thoracoabdominal aorta. And from my perspective as an aortic surgeon, this is where I think shared decision making is very, very important. The distal aorta, the thoracoabdominal aorta, these surgeries are far larger and more involved and carry a lot more risk. So this is where we would to have a lot more conversation and wouldn't necessarily just rush into surgery at 5 centimeters. We would lower the threshold then to 4.5 centimeters if there are these risk modifiers. So family history of dissection, rapid growth, diffuse root and ascending geometry, and vertebral tortuosity. So the diffuse root and ascending phenotype, so that is based, I look back on the references, and it's based on an older paper. So I don't think there's strong evidence for this, but and what this exactly means. But the idea is that certain configurations may be more malignant than others. The vertebral tortuosity work, that's actually not specific to Marfan syndrome only, but to other genetic disorders as well. And then there's this idea that the size thresholds should be indexed, not just to index, and as you know, patients with Marfan syndrome can be quite tall, and so the thresholds may vary depending on the patient's size. We would expect the normal aorta for a 6'8" person to perhaps be different from a maybe 4'10" individual, and so there's this idea of indexing is very prominent in the guidelines and outside of the nsHTAD section, in fact, and certainly it's pertinent to the nsHTAD section itself too. And so the threshold here is based on the cross-sectional area of the aorta divided by the height of the patient, and the threshold is 10 centimeters squared per meter. Okay. And so these studies from Dr. Svensson and Cleveland Clinic, they did focus on Marfan as well as focus on the bicuspid aortic valve populations. Now, moving on to Lois-Dietz syndrome, the baseline threshold, surgical threshold there is 5 centimeters, but it also depends on the genetic actual genes involved, and Dr. Milewicz already talked about that, where at 4.5 centimeters is where you would lower the threshold if you had TGF-BR1, TGF-BR2, SMAD3, or TGF-B2. The guidelines recommend an even lower threshold of 4 centimeters if you're a woman with TGF-BR2 and small body size. Again, talking about the idea of indexing. And then if the patient has severe extra-aortic features, if the patient has a family history of aortic dissection, or has a fast-growing aorta. Next, I wanted to talk about Turner syndrome. So patients with Turner syndrome are generally very small in stature. And so this idea of an absolute aortic size no longer is so relevant to this population. So for the adult Turner patient, we use the aortic size index. So this aortic size index is defined as the aortic diameter divided by the patient's BSA, body surface area. And so the threshold here is 2.5 centimeters per meter squared. There are modifying high-risk features, again, for this, for Turner syndrome, and that includes having a bicuspid aortic valve, having coarctation, and having hypertension. Then moving on to bicuspid aortic valve. So this is the most common congenital heart disease that we have, and it's very variable in its presentation. It can also occur in patients with Lois. It can happen in patients with Turner syndrome, and so it can happen in the context of other genetic diagnosis. But it most commonly actually occurs on its own. And so in these patients who do not have the other genetic diagnoses, just on its own, the threshold is actually the same as with tricuspid aortic valves as 5.5 centimeters, but can be lowered in certain circumstances. So this includes, so it gets lowered to 5 centimeters if the patient is being treated with a multidisciplinary aortic team where they have excellent outcomes and low risks with the surgery. In the context of a family history of aortic dissection, rapid growth, aortic coarctation, and the guidelines also describe the root phenotype as being more malignant. So the root phenotype being this one here that I'm circling. So there is a recognition that not all bicuspid aortopathies are the same. We have patients who have a normal size root and then a large ascending. We have patients who have this fusiform large everywhere aorta, and we have patients who have a predominantly large aortic root, but relatively normal ascending aorta. And the feeling is that the root phenotype is more malignant, although I think the evidence for that is not as strong as we would like. The size threshold is lowered even further to 4.5 centimeters if you are also coming for aortic valve surgery, and that makes a lot of sense. We would hate to have to bring the patient back in a few years for redo surgery. Again, the cross-sectional area index to height criteria of 10 centimeters squared per meter has also been specifically studied in the bicuspid aortic valve population, and so I mention it here. So moving on to the type of surgery that we perform, I wanted to make a comment on valve sparing root replacement for patients with genetically triggered aortic disease. This actually is one of the key take-home messages from the guidelines in the first page of their document, and I just wanted to make sure that patients with Marfan syndrome and other genetic diagnoses that the mainstay of treatment for proximal root aneurysms is the valve sparing root replacement, and that's because of Dr. David and as well as other surgeons work in this area that show that there's very good long-term outcomes with this particular operation. So when we are able to save the valve and not replace the valve when changing the root, we can do this operation with very good long-term results, freedom from reoperation, freedom from valve regurgitation, and studies have been done to compare it to mechanical and bioprosthetic valve replacements. That being said, I think it's very, very important to know that a bad repair is far worse than having a Bentall or a valve replacement done. So there are many, many reasons why a valve sparing operation may not be the surgery of choice. For instance, in an aortic dissection context, if you're it's a very specific scenario where it may not be a good idea. If the valve leaflets are not suitable for repair, if it's a bicuspid morphology, has calcium on it, and that just does not lend itself to a durable repair, then a Bentall with a valve replacement is a fantastic option and should not be poo-pooed. That being said, I do think that knowing about this valve sparing root operation and seeing if it's an option for you is important, so that you can advocate for yourself. And then when it comes to surgery on the distal aorta, I wanted to mention that open surgery is still the mainstay. So open thoracoabdominal aortic repair remains the mainstay for patients with Marfan syndrome, Lois syndrome, and other genetically triggered aortopathy, and the reason is that endovascular repair in this realm has been a bit disappointing in its outcomes, and open thoracoabdominal repair can be done well and safely in a high volume center, and should be done in a high volume center. There are caveats. So in a rupture scenario, endovascular repair can be very good in temporizing the situation, and does not burn bridges for needing open repair if that's the next step. And also, if you've had previous aortic surgery and we're able to land an endograft in graft to another graft, that can be a safe and type of configuration as well for patients with genetic diseases. So I wouldn't say that it's not an option, endovascular repair for patients with Marfan syndrome, et cetera, but it's something that has to be thought about very carefully. So just to recap, so size thresholds, they are the what we make all our decisions on, but they are modified based on the patient's genetic diagnosis and other high-risk features. Shared decision-making is very, very important. Contemporary aortic care takes place in multidisciplinary aortic centers, and valve-sparing root surgery and open thoracoabdominal surgery are the mainstay for patients with nsHTAD. Okay, and thank you very much.
Great, thank you, Dr. Milewicz, and thank you, Dr. Chung, for going through these guidelines with us. There was a question from a patient who would, like to comment on the use of beta blockers and ARBs in patients with ACTA2 mutations. Dr. Milewicz, could you share your comments on use of both of the medications on ACTA2 mutation?
We don't have any data. The only data we have in terms of beta blockers and ARBs are in Marfan patients. So we're taking that data and applying it to other conditions. My recommendations are to start with beta blockers and then add on losartan if they tolerate a second drug, but to start with the beta blockers because we've been using that for a much longer period of time. We have data that it blocks dissections, but not completely, but helps prevent dissections. We only have data on losartan that it slows aortic growth. We have no data that it blocks dissections. So start with beta blockers. I would like everybody with nsHTAD to be on a beta blocker or ARB or both, whether they have an enlarged aorta or not.
Right. Yes, and a question from a patient who is being followed by MRIs every year, but is a bit concerned about if there would be any kind of feeling that there is a growing aneurysm or a faster growing aneurysm. So basically, are there any kind of symptoms for aneurysms, or is the yearly follow-up good enough for patients who have genetic disease, aortic disease?
In the vast majority of cases, there are no symptoms associated with aneurysm growth. If it gets really big, it can start compressing on other organs in the thoracic cavity. But in the vast majority of cases, there's no symptoms. There are symptoms associated with an acute aortic dissection. The number one symptom is that chest pain or back pain or even abdominal pain in some cases, and that is sudden onset and often described as tearing, which makes sense. And people know something is wrong, but the aneurysm growth is usually not any symptoms. Dr. Chung, do you want to comment on that?
No, I agree. I think this is why there is so much data is so important in terms of promoting education on this topic, because it's a silent disease for the most part, right? So unless you did that screening, so you talked about all the cascade screening that and so on that we do. If it was as simple as you feel it and then you know you have it, then we wouldn't have to do all this intensive imaging that we do. So our aortic clinic, this is essentially an imaging surveillance clinic is what it is. And we meet with the patient and plan for the next imaging. And I think it's important. I think it can be tailored to each patient, how much imaging you do, how frequently you do it, the mode of imaging, but not being lost to follow up is key. Especially if you have nsHTAD, to not be lost to follow up.
Yes, absolutely. And just one more comment, going back to the beta blockers and the ARB question. The number one thing to remember if you have a genetic predisposition for thoracic aortic disease is to control your blood pressure. So those aortic growth and dissections are dependent on what's going on in the aortic wall, and some of that sort of like instability of the wall that leads to dissection is genetically determined. But the other factor that determines growth and your risk for dissection is how hard that blood coming out of the heart is hitting that aortic wall. And so if you let your blood pressure go high, out of control, you're just increasing your risk for dissection. So that's why we really recommend that people with aortic risk monitor their blood pressure at home and make sure it's okay. And number two, avoid exercises that drive up the blood pressure. And those are mostly isometric exercises. Aerobic are fine. That's the running and walking. We don't want you training for a marathon if you're at risk for a dissection or you've had a dissection, but getting out and exercising is, our data currently say it's good for any cardiovascular condition. And the data is indicating, the early data indicates it's good for thoracic aortic disease, but we need a lot more data. And that's one of the areas that we probably need to put some money into to make sure to define what exercises don't drive up somebody's blood pressure when they have an aneurysm or have had a dissection. And then also how much exercise can you do? And there's even some data in animal models that if you exercise, it actually decreases the rate of growth of the aneurysm. So that goes along with everything we know about cardiovascular disease, that exercise, that aerobic exercise is good.
Yes. Yes, and when it comes to genetic testing, patients who come into clinic, how is genetic testing offered to them? What kind of genetic testing is done? Is it for the gene panel? How is the decision on genetic testing made for a patient to be diagnosed?
And I want to just add to that, Chris-Ann, that if we could address this from both the US and Canada, because obviously we have a different system and access to that type of care. and, you know, people who might have other diagnosis in their family, or they may just have a number of events that have happened, as you talked about in the guidelines, about lots of aneurysms and dissections, you know what I mean? How to access genetic testing in both of those scenarios.
So any physician can order genetic testing, and I think the geneticists come in for, number one, making sure that all the family members get carefully evaluated, and number two, to interpret the results, which is sometimes difficult. The testing is very easy, that it will be explained to the patient, and we ask for them to sign a consent to have the genetic testing done, so they understand that this is important for them, but has implications for their family members too. And then all you have to do is spit into a little tube, because we can get DNA out of your spit. And then that is sealed and sent to the genetic testing companies. And I believe even in Canada, it goes to companies. And that usually takes 4 to 6 weeks to get the information back. And the information comes back in 3 different ways. Probably the most common is that they don't find the genetic variant causing the disease. And then we defer to just imaging everybody at risk in the family, and doing that imaging, even if it's negative, repeating it every 3 to 5 years until they reach a certain age. But if it's, the other possibility is they come back with a mutation in one of the genes that we know causes heritable or genetically triggered aortic disease. And then they are put on a management guidelines based on that gene. And then finally, there's also a result where they come back with the variant in one of the known genes, but we're not sure if it's disease causing or not. And once again, that's another area of research to really figure that out. And number two, in the meantime, until we know, it really defers back to being negative. And so we have to image everybody, and can't use that to go through the family and say, you're at risk, you're not at risk, even though you don't have an aneurysm, you have the variant, and we know we have to watch you carefully, get you on a beta blocker, losartan, and so on. And that's where the finding the gene is so powerful, because we can be very precise going through the family to say who's affected and who's not, and then how we manage it. So finding the gene is such powerful information to the person affected, but also the other family members. And I don't know if there's any other caveats for testing in Canada that I'm not aware of. Jennifer, do you?
So we still use blood. So it's a blood test here that we primarily do.
Absolutely no reason you need to collect blood. I can tell you that. There's no difference.
I'm sure that's the case. That our current pathway in our clinic is to draw the blood work and then send it off to CHIO in Ottawa to do the testing. So that's the current paid for by the government pathway that we have. And so I think those our limitations are mainly because of what OHIP, or for instance, will pay for. So this is what we're doing. So we are able to send that off if we identify a patient with that, but then we always involve our geneticists. So they don't come to every clinic, it's just not feasible. But if we identify such a patient, you're right, we can go ahead and send that blood work, but then we at the same time alert them, because of the complexities of the results that come back. Like you're saying, we will get back a variant of unknown significance, and we need the geneticist to weigh in and explain that, and to determine what the next steps are after you get the results.
Yeah,
Very good.
excellent. Dr. Chung, can you comment on, in terms of descending dissections, how long can they be managed without surgery? When, like, what's the decision call there for going into surgery for descending dissection?
Okay, so I'm going to interpret that as type B dissection. So the dissections involving the descending aorta, not the ascending, and the management strategy by the team was medical management, blood pressure control, and then to follow it. Which is the far and away the usual management strategy for that type of dissection. So every patient is quite different. We will see fast growers, patients within a year of having suffered that dissection. Their aneurysm will, the aorta will start to grow, and then we see patients who are very stable and doesn't grow for a number of years. So I don't think it's very predictable. We have a number of higher risk features on those dissections that can alert us to maybe some dissections would be faster growing than others. So for instance, if there's a large tear proximally with a lot of flow into the false lumen, we might consider those as higher risk features for growth. If we see it's been growing within the first 3 months, we might anticipate that it would grow rapidly in the first year, this sort of thing. But I think that the bottom line is that every patient is quite different, and so we do need to do imaging surveillance. So we actually did a study in Ontario, and it's an embarrassingly few number of patients get imaging surveillance after their dissections. So the key is to, again, not be lost to follow up. To see if you are the patient that is very stable, or to see if you are the patient that grows quickly. And the only way to know is to image. You're unlikely to develop symptoms. So for that patient who's asking the question, it's her case is very individualized. It's for her alone, and it may very well be very safe what's happening to her.
But I think it's also important to mention that after a type A dissection, the majority of the dissections will involve not just the first part of the aorta, but go all the way down the descending aorta. And those too can enlarge over time and have to be, even after you've had your dissection and had the first part of your aorta repaired, we still have to image the rest of the aorta to make sure it's not growing rapidly.
Yeah.
How often do you see it grow rapidly after a type A?
So 100% you're right, obviously, right? But that's why we have so many trials now about extending our repairs more distally to see if we can decrease that rate, because it's actually a large rate. So the most common type A dissection is the DeBakey-1, right? Is the one that affects the whole aorta. And so we only take care of the proximal portion during that emergency surgery. We're obviously not going to replace the entire aorta, just the life-threatening portion. And then the other part is left behind. And a good, so after a type A repair, if you survive your type A dissection, your 10-year rate of needing a reintervention, something on the order of 17%. So that's our Ontario data. So 17% of patients will be back after type A, after already surviving their type A dissection, going home. So if you're part of that population, within the next 10 years, you have up to 1 in 5 chance of needing some sort of reintervention. And what our data shows is that most of the people come back with urgent repairs, actually. So it would be better, obviously, if it was elective.
Is that because they weren't getting the imaging and
Yeah,
they have a leak or?
exactly.
That's bad. Get your imaging, follow your doctor's recommendation, please, and take your blood pressure and the beta blockers. Even after you survive the dissection, those beta blockers are important.
Yeah.
Question. Sorry. Sorry, Chris-Ann. I was just going to say there's a good question here. Wondering to compare the 2010 guidelines and the 2022 guidelines. And what is your opinion are the most important changes that have been made in these new guidelines?
I think we talked about a lot of the changes. That is based on the genetics. We've come a long ways in the genetics, not only in finding new genes, but defining that precise management based on the gene or the specific variant. So those are big changes. The real emphasis of the fact that 1 in 5 individuals will have a heritable form, and we can use that for identifying people that might be at risk has been really emphasized. Both Dr. Chung and I talked about the shared decision making, the recommendation for going to a center that does a lot of repairs and has a multidisciplinary team ready to take care of you before and after the surgical repair is really important. And then there are other changes. A lot of it is that we are including the entire aorta. So there's a whole section on abdominal disease that weren't in the previous guidelines, and a lot more details on other aortic conditions like aortic ulcers and so on. And then the big change is that whole endovascular repair that has exploded in the past 10 years. And Jennifer, maybe you can talk about the specific updates in terms of the endovascular repair.
So for the descending thoracic aorta, endo is if you can have endo, you should have endo. There's almost no question there. But for patients with heritable thoracic aortic disease, I think you could have that conversation, okay, about, because there are higher risks of having dissections with endovascular repair and having a less durable repair with endovascular repair. But for the run-of-the-mill patient, endo has absolutely exploded, like you're saying, and we use it a lot in our center for descending thoracic and also thoracoabdominal, and now we're doing more and more arches endovascular as well. So so that's a very exciting avenue that we're really trying to push is the endo arch surgeries.
But does that, Dr. Chu, does that really, but that's not generally appropriate for people with certain most genetic aortic identified disorders.
That's
and
correct.
I think that's the important part that I want to make sure people realize that. Yeah, it's for the right person.
Yeah, yes, absolutely. Hopefully I highlighted that enough in my talk as well. But it has a lot of issues with durability, causing more dissections, causing issues, and so in patients with such fragile tissues as the patients with Lois, for instance, so open surgery is still the mainstay for that type of patient, but there are certain scenarios where it may be appropriate for the extremely high risk patient to temporize things. If you're landing in graft and going into graft, that could be a safe configuration as well because the patients had previous surgery. So there are different scenarios where it may be appropriate.
And it really is important to mention that it can be used in anybody in the emergency situation. Like if you're one of those people with the descending thoracic aortic rupture, putting that graft in rapidly can save your life. So if the doctor says to you, you have Marfan Syndrome or Lois and says, we have to put this in, you're bleeding, then let them do it. They know what they're doing.
Right, that's right.
Don't argue with them.
Yes, absolutely.
Yeah, I think there was a question that we received is, the types of surgical decisions before a dissection and, with when you go in an emergency dissection. I'm not sure if any of that would have answered this question is what kind of decisions can you make electively for a surgery versus when you go in an emergency surgery?
Well, I think the shared decision making comes in oftentimes when somebody just can't live with the anxiety of knowing that they're at risk for a dissection. Because for some people, it just becomes an overwhelming factor that they can't live their life worrying about a dissection.
Yeah.
And then another case is when it comes up is when you see lots of early dissections in the family. And it's like we had a family with a PRKG1 mutation where a mother lost her husband and 2 of her sons to dissections, and 2 of the sons had an aorta just at the upper limit of normal and still dissected. And so we sat down with the family that she had 1 surviving child that also had the mutation and had a completely normal aorta, but the decision was made just to repair it because we knew that given her very young age, she was only 17 at the time of the repair, but one of her brothers died at 18, another died at 19. And so she was approaching the age where she was at risk. We know that males and females with that mutation are at the same risk for dissections. So given all that information, we repaired her aorta. It was completely normal. And she did great. She's doing well. She's, off to college and so on. And so hopefully that was the right decision to make with the family. And once again, the mother was frantic. I mean, she had already lost the 3, 2 sons and her husbands to dissections. Didn't want to lose her last surviving daughter.
Yes. So another question, someone with nsHTAD or genetic aortic disease, what other cardiac or vascular events might be associated besides aortic dissections, and what is the kind of surveillance, or how is this monitored for other vascular disease in these patients?
Well, we know for Marfan syndrome that after you have your aortic root ascending repaired, hopefully before it dissects, that you're an individual's risk for going on to have aneurysms in the brain or elsewhere in the body is pretty low. They are at a risk for that type B dissection, the descending dissection. But our current data still says that's probably what Dr. Chung, around 10 to 15%. It's not really high, but it's there, and we don't really have a way to prevent that. We still recommend imaging of the aorta in those individuals, but it typically is not dependent on size of the aorta. When those dissections occur, they can dissect at a completely normal size. The story is very different for those Lois Dietz genes, and we know that they can go on to have aneurysms elsewhere, including their brain, and then any artery coming off of the aorta is at risk. So we recommend head to pelvis imaging for everybody. We're pulling data out of MAC to say it's currently recommended every 2 years. But that's probably overly aggressive because the majority of patients do not go on to have aneurysms or that require repair or dissections or ruptures. Actually, ruptures are incredibly rare in our MAC cohort in LDS patients. Ruptures outside of the aorta are very rare. And so we really want, and something like TGFB2, all the cases are of other aneurysms right now in MAC are in the brain, or do we have to image the rest of in those patients? We don't know yet. So we really are getting ready to put out the first paper on the other aneurysms, but we just need a lot more data and have everybody putting their patients are consented to put their data into the MAC registry, but then we can use that data to really come back to the patients and tell them more about what they have to worry about, what we have to do as doctors to prevent. And then something, it's completely different for ACTA2 patients. They do not have much of a risk. They have little to no risk of aneurysms and dissections elsewhere. They are at with specific mutations in the gene, they're at a very high risk for the arteries blocking instead of growing bigger or dissecting. And that can lead to early onset strokes or to early onset heart attacks and heart disease because the coronary arteries get blocked. And we are working on very specific to say if you've got an ACT2 mutations, which ones lead to atherosclerosis and which ones lead to the cerebral vascular disease. And we have a large amount of data coming out with that. For the mutations that lead to atherosclerosis, we have very good data that being on high dose statin will help prevent the atherosclerosis. And we also know on data that we haven't published yet that the atherosclerosis goes way beyond the coronary arteries. It can really involve the carotid arteries and all the peripheral vascular arteries into the legs. So they can have a lot of problems with peripheral vascular disease or even atherosclerosis in their aorta. But in our model system, the animal model system, putting the animal on a statin early prevents all of that. So, and our mechanism that we figured out says that the statin should work. So, and then we're also working on a treatment to prevent the moya disease also, which we can prevent it in the mouse model with this. We now are trying to figure out how do we get this in a way to test in the patients. So.
Oh, thank you. Thank you. Lindsay, did you pick up on any further questions from you?
Just a last one. What about the pairs procedure? I know this does come up quite often and it's going to always come up, of course. And seems to be, this person's mentioning that the procedure and its benefits, and it is being reviewed for approval in the US. And is this something that is a possibility for the future?
Well, so I practice at Toronto General Hospital where we do reimplantation procedure primarily as it was developed here by Dr. David and Dr. Feindel. So the idea is to try and simplify it, or first we haven't found necessarily that it's so this tried and true valve sparing root replacement procedure with reimplantation has over 20-year data on, and we haven't found that it's required further a simplification, I guess. It has its results are transferable for sure to younger surgeons like myself, and so this is sort of our standard of care for this type of patient. When in the guidelines speak of valve sparing root replacement, it is this surgery that we're speaking of. I think innovation is great, and I look forward to newer data on this. Yeah.
I think one of the things about the pairs procedure is it has to be done with, or has been done with, like minimal enlargement. So you almost have to have the genetic trigger identified to go in and have it done, because it's done at and correct me if I'm wrong, Dr. Chung, the majority of cases are done before there's any significant enlargement of the aorta. In other words, at 4 centimeters, at 4.1, and that's still in an area where, you know, it's the upper limit of normal, and we're not really certain, can't say for certain the person's inherited the risk, but if they have that mutation, we know it's going to keep on growing. So it would have really limited applications for even genetically triggered disease.
Yeah, I think I was at a meeting where they did talk about you could do it in larger ones, but I think you're right that primarily it is for the
majority of the data has been from Marfan patients with little to no, very little enlargement.
Great. I think I don't have any other significant questions online. Chris-Ann, do you have anything else?
I think we're good.
Okay, great. Well, thank you so much for your time. I know it's a busy time. Thank you so much for your time.
Thank you.
Thank you. Oh, I think Chris Ann's frozen. So, okay. I don't know what's happened to Chris.
Sorry, I think I just dropped off.
Oh,
right.
you're back.
Well, can I just make a plug in terms of research that we're doing?
Of course.
I think we're as hopefully this webinar has illustrated, there's a lot of progress that we've made. These guidelines represent a significant update from 2010. But there's a lot of unanswered questions to go. TGH is very proud to contribute data and participate in Dr. Milewicz's MAC consortium. So thank you so much for that. Locally, we also do a lot of studies to try and prognosticate aortic disease. So we know, so we can, beyond size, just like Dr. Milewicz is looking at the genetics, we're looking at biomechanics and trying to figure out if we can determine the material properties of the aorta non-invasively. And we're also looking at flow hemodynamics as well, the shear stresses on the aorta. Like was mentioned earlier, you can, the dissections that happen after you've already had your proximal repair, this can be, say, several years later, it can be in a normal size aorta. So that's just knowing the size and geometry is not going to be enough for us in the coming years. And so this is what we're actively investigating.
Oh, that's very interesting. That's, you know, someone like me who's had root repairs and valve replacements, but my descending aorta is normal. But, you know, I'm a certain age where I'm thinking, yeah, it would be good to know if you know what I mean? You don't necessarily need a aneurysm to an active aneurysm to, you know, be a precursor for a dissection. So that's, yeah, definitely.
It was 14, I think it was 14% in the TGH series after a valve sparing root in the Marfan patient.
Yeah, so that's I'm glad you guys are studying that. If anything we can do to make sure you get more information will help. Hopefully get some patients in there.
I want to mention that we have ongoing research. If you're at a site that's not participating in MAC, you can go to the GATA website or the Montalcino Aortic Consortium website and just contact Houston, and we can enter your data directly into the database in Houston after you've consented for us to do that. And the other thing, we're really trying to find the rest of those genes. So if you have a family history and you yourself have aortic disease, but the testing's negative, once again, just contact me and we'd love to recruit you and our family into our studies. A couple of the genes we found using families from Canada specifically. So I'm grateful to those families for participating, and just with the more families we have in our study, the faster we're going to get to identify all the genes. And look for about, I don't know, another 6 more genes coming out in the next 6 months. So we're making progress, but once again, just the more unsolved families we have with genetically triggered disease running in families, the faster we can get at all those genes. And once again, all you do is have to spit in a tube and send it back to us. You don't have to leave your house to participate, because we consent you over the internet and then send you the tube to spit in, and you just send it back to us. That's it. We don't need blood like they do in Toronto.
Yes, that's great. Actually, I just want to add that GATA is also on a mission to drive participation in MAC, and so yeah, we are on a full-blown. You know, we want more participation for all the reasons that you just said, Dr. Milewicz. So I do want to thank both of you for this really invaluable session. Thank you for your participation and all the information that you've shared here. This session is recorded and it will be available. And I wish Dr. Chung and Dr. Milewicz the very best with your research, and we are here to help in whatever way possible that we can to drive it forward. So thank you, and stay connected. Thanks to everyone else who's attended this talk. Thank you for joining us at this time. And I wish everyone, all our friends in the US, a very happy and safe Thanksgiving holiday. Enjoy the weekend. Thank you very much.
If you have any additional questions or there was anything you needed more information on, you can always just email GATA at info@gatacanada.ca, and or on Facebook or Twitter, you can just connect with us. We're happy to get information from Dr. Milewicz and Dr. Chung if there are any very specific follow-up questions. So do get in touch.
Okay,
Thank you.
Thank you.
Bye-bye.
Bye-bye.
Bye-bye.